Hi, this is Nurse Inge, and you're watching Fetal Heart Rate Monitoring. External fetal monitoring or electronic fetal monitoring is more sensitive than a Doppler. It evaluates fetal well-being and oxygenation. We think about the question, how well are they tolerating contractions? For example, is there decreased oxygenation or blood flow? The nurse's responsibility is to independently assess, interpret, and intervene, and provide information, explanation, and support to the family to help decrease anxiety. External fetal monitoring is using an external ultrasound machine to listen to the Doppler flow through the stomach, and then the tocodynamometer is or the toco machine is the band that goes around the abdomen that measures uterine contractions. There's also internal fetal monitoring. So fetal scalp electrode can measure fetal heart rate, and intrauterine pressure catheters can measure the actual strength of uterine contractions. So externally, it's not as accurate, but obviously not invasive, and then internally gives us more information, but has increased risks of infection and injury. These steps to interpreting fetal heart rate monitoring are very similar to interpreting cardiac monitoring. So first of all, we want to kind of look at baseline, and we do baseline readings for fetal heart rates for 20 minutes at the onset of labor, and then as indicated by stage and risk. So to determine the baseline fetal heart rate, the first thing we do is average the heart rate in increments of 5 over a 10-minute period where there's no accelerations or decelerations. So you want to get this nice resting heart rate over 10 minutes, and then what's the average to the nearest fifth? Normal fetal heart rate is between 110 and 160. If the patient or the fetus is persistently below 110 for 10 minutes, that would be considered bradycardia. And if they're tachycardic, so greater than 160 for 10 minutes, then that's considered fast. Sudden bradycardia is considered an emergency, and prolonged tachycardia is oftentimes related to hypoxemia, but also could be related to something maternal. So maternal fever can cause tachycardia, and maternal medication use, stimulants, can cause tachycardia as well. Fetal hypoxia first causes tachycardia and then bradycardia as the cells can't function in an acidotic state. The normal cord pH is already 7.2 to 7.3, so we start out acidotic anyway. So as oxygenation is a lack of oxygenation is prolonged, or the baby is struggling for longer and longer, that you'll notice that they get tachycardic and then bradycardic. So that kind of sudden bradycardia tells us that there's something really critically wrong. After we've determined the baseline heart rate, we want to look at baseline variability. So over 10 minutes, where there's no accelerations and decelerations, you want to look at the peak and the trough. So what's the lowest heart rate and what's the highest heart rate? Absent variability means that it's pretty much flat. There's no change. Minimal means that it's about 5. So, kind of less than or right about 5. Moderate is normal, and that's 6 to 25. So a range of 6 to 25 beats per minute difference in the peak and the trough. Now, moderate variability is the most important predictor of adequate fetal oxygenation and reserves. And so one of the things we're really looking at is the heart rate increasing with activity or movement and decreasing at rest? And so those are important to have those kind of normal variabilities. And then marked variability is greater than 25. And that doesn't necessarily mean that there's something wrong, but just we need to keep an eye on that. So after we have determined baseline fetal heart rate and baseline variability without accelerations and decelerations, then we will continue to monitor for accelerations and decelerations. So we're going to monitor for accelerations, and this is the peak of a visually abrupt increase in fetal heart rate above baseline. that needs to be at least 15 beats per minute increase for 15 seconds or greater, but less than 2 minutes. So what we don't want is just to say like, oh, this kid's tachycardic for a period of time, but what we want to see is just a sustained increase in heart rate for at least 15 seconds. If you're doing a non-stress test in a fetus that is less than 32 weeks, then it's considered 10 beats elevation for 10 seconds. Prolonged accelerations last greater than 2 minutes, but less than 10 minutes, and persistent accelerations then would be considered tachycardia. Accelerations are demonstrative of fetal well-being and oxygenation, so we want to make sure that, again, they have moderate variability and they do have accelerations. They're predictive of adequate central fetal oxygenation and lack of acidemia, so the baby's getting enough oxygen and is not getting acidotic. Then we want to watch for and identify decelerations, and these are decreases from baseline that can be gradual or abrupt. Early decelerations are U-shaped. They mirror the uterine contractions. They're nice and gradual decrease and gradual return. Late are the onset after the peak of contractions, but they're a gradual decrease and a gradual return. Variable decelerations tend to have a very abrupt departure from baseline. They can be V-shaped, W-shaped, or U-shaped, but they tend to be much deeper, greater than a drop of 15 beats per minute, usually lasting greater than 15 seconds, but less than 2 minutes. So they're just these very wide, abrupt, and deep decelerations. And then prolonged decelerations last greater than 2 minutes, and they are at least 15 beats per minute in decrease, and so they last between 2 and 10 minutes long. They're just very gradual and long. And then we're going to look also at something called sinusoidal, and this is where we see a smooth sine wave pattern that basically kind of cycles in and out over multiple times over the period of time that you're monitoring them. They kind of cycle in and out of this sinusoidal pattern, and that's incredibly concerning for us. That's tier 3. So I put this little veal chop mnemonic up there because a lot of times, especially when you're starting out, it's easier to kind of remember something than it is to understand something. But I think it's important also to understand. So early decelerations are totally normal. As the baby is being compressed, they think that compression of the head just kind of compresses like the brain stem, and it slows the heart rate down, kind of stimulating the vagus nerve and the parasympathetic nervous system. And because it occurs with contractions and it returns to baseline as soon as the contraction is over and the baby doesn't appear to be in any other distress, early decelerations are not concerning, they're normal, and they tell us actually that labor is progressing. Accelerations are great, they're okay, but accelerations are wonderful because they tell us then that the baby's getting enough oxygen and they're not acidotic. So E and A, early decelerations and accelerations are both expected, anticipated. We are happy to see those. Late decelerations occur after the contraction has started, and they tell us that, oftentimes there's something wrong with either the uterus or the placenta in terms of oxygenation reserves. And so you can just see this if it's a post-date baby. You just keep an eye on this and make sure that there's nothing else going on. It could end up being a reason for concern if there are no accelerations or if there's no variability. But as long as everything else looks okay, late decelerations are just kind of okay, let's keep an eye on it. Variable decelerations concern us a little bit more because this means that the baby has some sort of cord compression, and it could be a positioning issue. So we'll talk about intrauterine resuscitation and kind of what we can do to try to improve concerning fetal heart rate patterns. Also be sure while you're doing these steps that you're evaluating the TOCO for uterine contraction frequency, duration, intensity, assess the resting tone of the uterus, and the relaxation time between uterine contractions. So step 1 is to determine the baseline heart rate. And the first thing that you're going to do is look over a 10-minute period of time and kind of average out the heart rate. So what we see in this picture is the minute markers. So this line would be 0 minutes, 1 minute, 2, 3, 4, and 5. So we have a 5-minute strip here. And when we look at this strip, you would kind of take a ruler and draw kind of down the middle of this here, which I'm not doing great with my pen, but you can see that you're kind of like in the middle. So if this is 120, and this is 130, and this is 140, and this is 150 up here, then you know, you're hitting at about like the 135 mark down the middle here. So it looks like it's ranging from, the lowest was about 120 to 125, and the highest was about 145. So we have an average heart rate of about 135. And then for our variability in this one, we have a range of about 20 beats per minute. So both of those are nice and normal, and we've measured this for 5 minutes. So obviously we'd have to measure it for another 5, but assuming that nothing changed, that would be normal. Persistent tachycardia then again is anything greater than 160. So in this strip you can see that this is at 180 beats per minute. So this is 150, 160, 170, and this line up here is 180. So this fetus is persistently at 180. And again, this would be 0 minutes, 1 minute, 2, 3, 4, 5, and 6. So this infant or fetus is 180 for 6 minutes. Bradycardia occurs when the heart rate is less than 110, and the 110 line is right here. And same thing, if this is 0, there's 1, 2, 3, 4, 5, almost 6 minutes that we've monitored total if you count the ends on both of these. But this fetus starts off at 80 and then goes up to 90 and then dips down and stays at 60. And so this would be an example of kind of a sudden bradycardia where we'd be super concerned about hypoxia and acidosis. So after we have assessed the fetal heart rate, we're going to look at baseline variability. So we're going to look at the peak and the trough. Absent, as you see in the top left here, is pretty much flat. There really isn't any variability at all. Minimal is, you know, up to 5. So you see in the bottom left-hand corner that there is some variability, but it's less than 5 from peak to trough. Moderate, again, is normal, and that's 6 to 25. And so you can see here that like this looks like it's about the lowest here, and then it gets to be about the highest here. And so that's about 20 on this strip. So that's definitely between 6 and 25. And then marked is greater than 25. So in this strip, it looks like it goes from about 105 all the way up to 170-ish. So 65. Oops. I can't find my mouse. There we go. So about 65 would be the variability for that one. So moderate variability, here's another example. 6 to 25 is normal, and you can't stress that enough. It's the most important predictor of adequate fetal oxygenation in reserves. And we want to see normal, moderate variability, which is a very reassuring pattern for us. Marked variability with some decels here, just to give you an example of like how this might play out or what this might look like in an actual, monitoring an actual patient. So we see that, the fetus is kind of jumping around quite a bit in terms of heart rate going up and down. They're anywhere from 100 to almost 180, and they seem to be having some decelerations, also, some corresponding to contractions and some not. So after we have assessed heart rate and variability, we are going to monitor for accelerations. And these boxes are 20 seconds long and 30 beats tall. So when you're looking at these little boxes inside the minute box, this would give you an idea of kind of what you're looking at. So this is 20 seconds here, and then another 10, so that's 30 seconds long. And then it's also 30, this upwards would be 10, 20 beats per minute high. So this is an increase of 20 beats per minute over 30 seconds. And then you see it happens again here, exactly the same. There's 30 seconds there with an increase of 20. So that's a good acceleration. Remember, an acceleration is at least 15 beats per minute for at least 15 seconds. And these are demonstrate fetal well-being and oxygenation and are very reassuring for us. So we want moderate variability and good accelerations. Then we want to watch for and identify decelerations. And this is an example of an early deceleration. Again, early decelerations are okay. This is when we have the deceleration that occurs kind of exactly the same as the contraction. So it's a nice, gentle U shape that just mirrors the contraction itself. And it occurs kind of in the start and stop are the same as the contraction that you see that the person is having. Late decelerations then start after the contraction and end obviously after the contraction. So these are not the same as early decelerations. So you can see how like the U's don't really match up, but they're still gradual decrease, gradual return. So not abrupt, not like super deep or ugly. Versus variable decelerations. And one of the things I think is helpful is if you remember that there's a V in variable and that you can have UVs or Ws in variable decels, but just notice how like dramatic the kind of decrease from, or the change is from the baseline, and that's totally different than we see from early and late deceleration. So you see there's just really abrupt decrease from baseline, and it goes definitely more than 15 beats per minute and lasts more than 15 seconds. And variable decelerations can happen anywhere during the uterine contraction cycle. So these really do match up with contractions, but they don't have to. They can occur at any point during the, or I should say even asynchronous to uterine contractions. Prolonged decelerations then last greater than 2 minutes, but less than 10 minutes, and they're gradual and long. So you see here that this one starts way back here and then just goes down and stays down and stays down and stays down and then gradually comes back up again. And so this one is 1, 2, 3, 4, 5 minutes worth of decelerations. And our concern obviously with that is that the baby is not tolerating the contractions well and is starting to get hypoxic. And then we have what's called the sinusoidal pattern. And so these again are these kind of smooth sine waves that can either be from fetal like acidosis and death, where we have a baby that is actively dying, or it could be from a baby who's actually rhythmically sucking their thumb, or from a mom who just got like Stadol or Nubain. So sometimes we'll have what's called a pseudosinusoidal pattern from a mom who received a medication, and that'll only last about like 20 minutes or so, and then it goes away. But it's important to recognize that there are certain things that we can do that make this occur, and it's not like a true tier 3 emergency where we need to run to C-section. So the 3-tier interpretation system kind of gives us guidelines for determining how reassuring or critical the findings are when we are monitoring fetal heart rates. So tier 1 is normal, continue to monitor, and this is where all findings are within normal limits. The fetal heart rate is 110 to 160. There's moderate variability, accelerations are present, and there's early or no decelerations. So again, early decelerations are great. We don't mind those. Accelerations are awesome. We like those. Variability should be moderate. We like that. And heart rate should be in the normal range. So all that is very reassuring. Just continue to monitor, do what you're doing. Tier 2 is indeterminate, and so we should intervene and then reassess. And this is anything concerning that doesn't meet the tier 3 requirements, like tachycardia and bradycardia, minimal or marked variability, loss of accelerations with fetal stimulation, decels are variable or prolonged, and if there are late decels, there's still some baseline variability between uterine contractions. So I know that there's a lot that just kind of falls into tier 2, but basically tier 2 is anything that just kind of like tickles your spidey senses where you're like, that doesn't seem quite right. It's not normal. It's not tier 1, but it's not like super critical yet. It's not tier 3. And so tier 2 is where we as nurses can make the biggest intervention, where we can make the biggest difference doing our intrauterine resuscitation. So tier 3 is abnormal, and this is where like you have to do something right away and tell someone right away because things aren't going well. And this is where you have absent variability with late decelerations, variable decels, or persistent bradycardia. That sinusoidal pattern absent of having just given like a medication, or prolonged variability with no decels. And loss of variability is concerning for fetal acidosis. So these are the things that we look at. Like there's just, thinking about all of these kind of put together. So like this is a child that is not tolerating the lack of flow and oxygen that occurs with contractions well. This is a child that is not like, tolerating labor well, and that probably needs a C-section. So the initial thing that we do, so then you'll want to do uterine resuscitation. So uterine resuscitation is where we roll the patient on their side. It could be left or right. If you put them on their left side, they don't get better. Try it on their right. Usually we just say left side because the vena cava is on the right side, but it really doesn't matter. You just don't want them flat on their back. Then you're going to give oxygen, because oxygenating the pregnant patient is going to help oxygenate the fetus. And if they're hypotensive, you want to give IV fluids. But if they're hypertensive or if they have heart disease, you don't want to fill them full of fluid. Decrease oxytocin if you're inducing them or augmenting them and they're experiencing tachysystole, because that could that does decrease blood flow to the uterus as well as to the placenta and therefore the fetus. And this is where you have fast uterine contractions, more than 5 and 10 minutes, lasting greater than 2 minutes apiece, with a less than 1 minute diastolic or relaxation time in between, which means then that you have decreased ability of the placenta to get reperfused, and so the fetus then gets hypoxic and acidotic. There's increased uterine tone, increased uterine pressure with tachysystole, and if you need it, the antidote would be a tocolytic like terbutaline, which is a beta-2 agonist. Amnioinfusion is the introduction of a sterile catheter and sterile installation of normal saline or lactated ringers into the uterus to replace lost volume, and that decreases compression of the cord. We use it to clear or thin meconium. We use it to replace lost fluid and to take pressure off of the cord. And we can do usually about 250 to 500 milliliter bolus or 180 milliliters per hour. So that's fetal heart rate monitoring in a nutshell. I hope that this helps you. Please let me know if you have any questions. And always, as always, thank you for watching.